Exacerbations, effective management of exacerbations incorporates the same four components of asthma management used in managing asthma long-term: assessment and monitoring, patient education, environmental control, and medications. Early treatment by patient at home is the best strategy for managing asthma exacerbations. Patients should be instructed how to recognize early indicators of an exacerbation, including worsening PEF. Use a written asthma action plan that notes when and how to treat signs of an exacerbation. A peak flow based plan may particularly be useful for patients who have difficulty perceiving airflow obstructions or have a history of severe exacerbations. Adjust their medications by increasing a short-acting beta agonist, and in some cases adding a short course of oral systemic corticosteroids. Doubling the doses of ICSs is not effective. Remove or withdrawal from allergens or irritants in the environment that may contribute to exacerbation. Monitor response to treatment and promptly communicate with the clinician about any serious deterioration in symptoms or PEF, or about decreased responsiveness to a short-acting beta agonist treatment, including decreased duration of effect. So management in the urgent or emergency care setting should have pre-hospital protocols that allow administration of a short-acting beta agonist to reverse airflow obstruction rapidly, supplemental oxygen to correct significant hypoxemia, and moderate or severe exacerbations. And with appropriate medical oversight, anticholinergics or oral systemic corticosteroids to decrease airway inflammation in moderate or severe exacerbations, or for patients who fail to respond promptly and completely to short-acting beta agonist treatment. To patients who have signs or symptoms of asthma exacerbation, and remember to monitor response to therapy with serial assessments. Differential diagnostic possibilities for asthma should be considered. Recurrent episodes of cough and wheezing most often are due to asthma in both children and adults. However, other significant causes of airway obstruction leading to wheeze must be considered with both initial diagnosis and if there is no clear response to initial therapy. Additional pulmonary function studies will help if there are questions about COPD or a restrictive defect or a VCD. Bronchoprovocation with methacholine, histamine, cold air, or exercise challenge may be useful when asthma is suspected and spirometry is normal or near normal. For safety reasons, bronchoprovocation should be carried out only by a trained individual. A positive test is a diagnostic for airway hyperresponsiveness, which is a characteristic feature of asthma but can also be present in other conditions. Thus, a positive test is consistent with asthma, but a negative test may be more helpful to rule out asthma. Chest x-ray may be needed to exclude other diagnoses. Biomarkers include total and differential cell count and mediator assays in sputum, blood, urine, and exhaled air. There are some common diagnostic challenges that are important to keep in consideration. Cough can be the principal or only manifestation of asthma, especially in young children. VCD can mimic asthma, but it is a distinct disorder. VCD may coexist with asthma. Asthma medications typically do little, if anything, to relieve VCD symptoms. Variable flattening of the inspiratory flow loop on spirometry is strongly suggestive of VCD. Diagnosis of VCD is from indirect or direct vocal cord visualization during an episode during which abnormal adduction can be documented. VCD should be considered in difficult to treat atypical asthma patients and in elite athletes who have exercise-related breathlessness, unresponsive to asthma medication, and gastroesophageal reflux disease, obstructive sleep apnea, and allergic bronchopulmonary aspergillosis may coexist with asthma and complicated diagnosis. So children's ages 0 to 4, the diagnosis in infants and young children is challenging and is complicated by the difficulty in obtaining objective measurements of lung function in this age group. Caution is needed to avoid giving young children inappropriate prolonged asthma therapy. However, it is important to avoid underdiagnosing asthma, thereby missing the opportunity to treat a child by using such labels as wheezy bronchitis recurrent pneumonia, or reactive airway disease. The chronic airway inflammatory response and structural changes that are characteristic of asthma can develop in the preschool years, and appropriate asthma treatment will reduce morbidity. Consider referral to an asthma specialist if signs and symptoms are atypical, if there are problems with the differential diagnosis, or additional testing is indicated.